Hello everyone, my name is Owen Brennan, Medical Affairs Dietitian at VitaFlow International, and I'm very happy to welcome you to today's webinar hosted by VitaFlow titled Transition from Second to Third Stage Protein Substitutes in PKU, Implementation Challenges and International Survey Results. This webinar aims to support healthcare professional education with regards to the dietary management of children with PKU. A few housekeeping items before we get started. The webinar is intended for healthcare professionals only. The webinar will last approximately 60 minutes and will include time for questions at the end. If you would like to ask a question, please use the question feature on your screen. All questions will be screened and a select number will be answered by the speakers at the end of the presentation. The webinar is being recorded and will be available on VitaFlow's website for healthcare professionals education, VIA, in a few weeks' time. A PDF of the presentation slides will also be made available in the coming weeks, and a feedback form link will be sent to you via email after the webinar. We now move on to the disclaimer. Now, I won't read the whole thing, but just to say the financial support for this presentation was provided by VitaFlow International Limited, and the views expressed herein are those of the presenters and do not necessarily represent VitaFlow's views. The learning objectives for today are to explore the importance of a child's emotional development and maturity with protein substitute change, have a greater awareness of the challenges in successfully transitioning protein substitutes, and lastly, to increase your knowledge of the variation in clinical practice for this key milestone. It is now my pleasure to introduce our speakers for today's presentation. In a moment, I shall pass you to Özlem Yilmaz-Naz. Özlem graduated with a bachelor's degree in nutrition and dietetics in 2014. She embarked on her career as a dietetic research assistant in Turkey and has since been actively involved in multiple research projects focusing on the dietary management of IMDs, particularly PKU, at Birmingham Women's and Children's Hospital. She has published several peer-reviewed papers and presented at national and international conferences. Özlem is currently a doctoral candidate under the guidance of Professor Anita MacDonald. Her PhD project centres on understanding the transition from second to third stage protein substitutes in PKU. She aims to create a comprehensive guide that helps improve the transition process for patients, parents/caregivers, and healthcare professionals. After Özlem's presentation is completed, the second part of our webinar today shall be presented by Professor Anita MacDonald. Professor MacDonald is a consultant dietitian in IMD at Birmingham Children's Hospital in the UK and an honorary professor in dietetics at Plymouth University. She has a wealth of experience in paediatric dietetics, having worked as a clinical dietetic specialist for 40 years. She is a fellow of the Royal College of Paediatrics and Child Health, and her involvement in aspects of IMD has spanned most of her working life. Professor MacDonald obtained her PhD in PKU in 1999 and is actively involved in all aspects of IMD research and development in this discipline. She has extensive research experience with more than 400 publications and has lectured in more than 30 countries on topics relating to nutrition.
Hello everyone, I am Özlem Yilmaz-Naz, a research dietitian from Turkey. Today, I will be sharing our global survey results on transitioning PKU patients from second to third stage protein substitutes. Protein substitutes are an integral part of dietary treatment in PKU. They provide all amino acids except phenylalanine and supply additional tyrosine that otherwise may be deficient. They are also usually supplemented with vitamins, minerals, and long-chain fatty acids to meet nutritional requirements. The amino acids provided by protein substitutes are essential for the synthesis of body protein and nitrogen-containing compounds such as hormones, enzymes, and some neurotransmitters. Their nutritional profile and overall composition are essential for supporting normal growth and biosynthetic functions. There are different types of protein substitutes designed to meet the nutritional and developmental needs of patients with PKU. These include first stage, second stage, and third stage protein substitutes. First stage protein substitutes are introduced in early infancy after diagnosis. These phenylalanine-free infant powders, reconstituted as liquids and delivered through infant feeding bottle, and mirror the nutritional composition of standard infant formula without phenylalanine. As infants grow, they require more phenylalanine-free infant formula, but higher volumes may delay solid food intake by reducing appetite. So from 6 months of age, a second stage weaning protein substitute with higher protein and lower energy is gradually administered. There is also third stage protein substitutes suitable from the age of 3 or 4 years or older. And these third stage protein substitutes are ready to drink liquid, casein glycomacropeptide, slow release protein substitutes, tablets, capsules, or bars. Transitioning from one protein substitute to the next is essential in ensuring acceptance, establishing routine, simplifying administration, encouraging child independence, and to meet changing nutritional requirements with age. In this study, we aimed to assess the global clinical practices in transitioning young children with PKU from second to third stage protein substitutes. A 31-item questionnaire on protein substitute transitioning was emailed to around 300 healthcare professionals working with PKU. The questionnaire remained open for 8 weeks from March to April this year. We asked questions on 3 key topics. The first topic was about the general transition process. So we asked professionals about the average age and how long it usually takes to transition to third stage protein substitutes, as well as their general approach. Who is the primarily responsible for it, and whether they engage nursery or school during transition. In our second topic, we asked questions about the type of third stage protein substitutes that commonly used and factors influencing this choice. We also asked if children switch to different type of third stage protein substitutes later on, and whether GMP protein substitutes are prescribed. Lastly, we wanted to explore the common facilitators and barriers that healthcare professionals encounter during the transition process and any potential suggestions to improve it. Let's dive into the results. We received a total of 110 responses from 32 different countries. The majority of centers managed both children and adults with PKU. The mean number of PKU patients under the age of 16 years being treated at each center varied widely, ranging between 2 and 1,200, with an average of 100 patients per center. This first chart here shows us the average age when children start transitioning. Now, as you can see, the third stage protein substitutes are introduced at various ages. Despite this, it can be anywhere from 1 to 2 years old to all the way up to after 10 years old. Despite these wide ranges, there were some common patterns. So the majority of professionals, this is around 42%, said that transition usually starts between 3 to 5 years. 32% said it usually starts between 6 to 10 years, and 13% said transition starts after 10 years old. We did get about 4% of the responses labeled as non-applicable since they weren't relevant to the context. Now, let's talk about what influences this timing. So there are multiple factors that come into play here. Some professionals said because children at this age are more open to change. Some said because third stage protein substitutes align better with the nutritional requirements. Some find the third stage protein substitutes more practical for nursery or school. And some of them said it's because children at this age start seeking for more flexibility or independence in their choice. And some give their decision based on what's recommended by their country or by the manufacturer or because of the reimbursement rules in their country. In this figure, we can see the average transitioning duration. So now again, as you can see, there is a wide range of transitioning duration between less than a month to up to 5 to 10 years, although this longer duration was only reported by one healthcare professional. Now, what's interesting is that the majority of professionals, that's about 71%, said that transition is usually completed within 6 months. To get into more detail, 28% of them said transition usually takes less than a month. 25% of them said it usually takes 1 to 2 months, and 18% said it typically lasts between 3 to 6 months. For 18% of the professionals, the transition duration either depended on individual circumstances or remained unknown. When it comes to guiding children through the transitioning process, dietitians play a central role with making up 82% of the responses. In 9% of the cases, doctors were in charge, and in another 9%, both doctor and dietitian worked together during transitioning. Let's have a look at the transitioning methods that healthcare professionals use during transitioning. We asked whether they prefer a step-by-step approach or an immediate changeover. There is again quite a diversity of methods in use, but the majority of them, this 42%, said they use a step-by-step transition, transitioning children to the third stage protein substitutes gradually. Another 28% said they prefer an individualized approach, tailoring the transitioning process to each children's preferences and needs. And 27% said they prefer an immediate changeover, changing the children to the next protein substitutes quickly. When it comes to involving nursery or school staff during the transitioning process, we asked professionals whether they involve school or nursery staff, and the majority of them, that's 69%, responded with a no, and 31% said yes, indicating that they do engage the help of nursery or school staff during the transitioning process. Among those healthcare professionals who said yes, only 35% of them actively involve nursery or school during transition. This active involvement takes various forms, such as contacting them directly, preparing care plans, conducting nursery visits, or providing written information. 18% of the professionals said it depends on the family or school, and 9% said nursery is involved only when it's needed. And 9% said usually parents take the initiative to contact school themselves. 29% of the professionals didn't provide clear or extra information. As you may recall, in our second topic, we wanted to explore the most often used types of third-stage protein substitutes and factors behind these. So we began by asking professionals about the commonly used types of third-stage protein substitutes. And 77% of them, that's roughly 3 out of 4, said ready-to-drink liquid forms are the types that most commonly used. Powder forms are the second most popular choice, selected by 60% of the professionals. And other options like tablets, bars, and granules were only selected by less than 10% of the professionals. Now, let's talk about the factors that healthcare professionals consider when choosing the type of third-stage protein substitutes. They had the option to select multiple choices, and here is what they told us. Patient or parent preference, as you can see at the bottom, was a top consideration for the majority of them. And another influencing factor was ease of use, with 65% of the professionals acknowledging its importance. Again, nutritional composition was reported by around half of the professionals. And other factors such as product reimbursement, availability of samples, child age and maturity, and experience with older siblings, although slightly lower in percentage, these factors also collectively contributed to the decision-making process around the choice of third-stage protein substitutes. Next, we asked healthcare professionals if children with PKU tend to switch to a different type of third-stage protein substitutes as they aged. In our survey, we made it clear that this change is not related to the modifications in package size or flavors. Instead, our primary focus was on the changes in the type of third-stage protein substitutes itself. So what did we find? Well, 53% of the professionals said yes, indicating that subsequent changes do happen. Let's look at the most commonly reported reasons for subsequent changes. So the most commonly reported reason is, as you can see down below, child resistance due to taste, smell, or texture. And another, this is followed by, again, child resistance, but this time due to volume of the third-stage protein substitutes prescribed. Other frequently reported reasons included supply issues, gastrointestinal problems, specific age indication of protein substitutes, and deterioration in metabolic control. We also asked professionals if they prescribe GMP protein substitutes during transitioning. So the majority of them said yes, while 17% choose not to use GMP protein substitutes during transition. And 21% said GMP protein substitutes are not available in their country. Professionals with access to GMP protein substitutes consider several factors when deciding whether to prescribe GMP protein substitutes. So, as you can see, taste and acceptability is what matter the most for majority of them. However, this is not the only influencing factor. Healthcare professionals also consider phenylalanine tolerance, dietary adherence, and metabolic control when deciding whether to prescribe GMP protein substitutes. 14% of the professionals reported a preference for GMP protein substitutes due to their potential advantages, including improved satiety and absorption, better gastrointestinal tolerance, and their potential benefits on gut microbiota. Let's look at the last topic of our survey, where we looked into the commonly reported facilitators, barriers, and suggestions to improve transitioning process. So healthcare professionals reported several facilitators that make the transitioning process smoother. And here is what they told us. Child and parental motivation, as you can see down below, was the most commonly reported facilitator. And better taste, smell, or texture of the protein substitutes also reported by 67% of the professionals. And 57% mentioned that effective parental management strategies such as consistency, being calm and positive is an important facilitator during transitioning. And around half of the professionals said that child age and maturity and easy preparation of the third stage protein substitutes also help the transition, make the transition process smoother. And around 1/3 healthcare professionals said that anticipation of increasing child independence facilitate this process. Now, let's talk about the common barriers that healthcare professionals encounter during the transitioning. Taste, smell, or texture is a big one, which is reported by 70% of the professionals. And this is closely followed by the aversion to new protein substitutes. And other commonly reported barriers included a lack of parental consistency, parental fear of change, high volume, and poor child behavior. Lastly, we asked healthcare professionals if there are resources or tools that are currently missing but would be helpful in supporting children and their parents through the transitioning process. And majority of them said educational videos would be helpful. And some healthcare professionals suggested creating step-by-step charts or books. And some recommended preparing guidance books and child rewards to motivate children. We also collected valuable suggestions through open-ended comments. And some professionals suggested more interaction between family and dietitian through virtual visits, home visits, and workshops. Also, some suggested creating fun resources for children, such as coloring books, comic books, games, and specialized apps. Also, some healthcare professionals mentioned about the importance of improving the taste of protein substitutes and expanding the available options. In conclusion, global clinical practices for transitioning to third stage protein substitutes varies, with many challenges and facilitators influencing the outcome of this process. There is a clear need for guidance and additional resources to better support children, parents, and healthcare professionals during the transitioning process. Thank you very much for your attention, and I also would like to thank all the healthcare professionals who took part in our survey and provided their valuable experience with us, shared their valuable experience. Thank you.
Thank you. Thank you very much, Özlem. Ladies and gentlemen, I will now continue, and a big hello here from Birmingham. It's not so pleasant this afternoon. It's a little bit chilly, but hopefully we can keep you going for that little bit longer and introduce a little bit sort of warmth into the area. But I'm going to continue with the theme of transitioning protein substitutes in PKU. I'm going to concentrate a little bit on what can go wrong. I'm going to take you through a series of challenging case studies and how we work through these. But why move on? Why transition? Özlem's already explained this. She's talked about age-appropriate nutrition and independence. I believe part of the reason why we need to move on is to try and narrow the differences between children with PKU and non-PKU children. If you're taking a liquid protein substitute from a pouch rather than a semi-solid protein substitute from a dish, it looks much more normal, much more acceptable. It will certainly help with feeding development, and it will help with appetite. If you haven't got to prepare the protein substitute 3 times a day as a semi-solid protein substitute, and you can just give a liquid pouch, it will ease the burden of care for the parent, and it will give the child much more choice. Now, the process of transition between a second stage and a third stage protein substitute, it is not an event that can happen overnight. It is really quite a process. This is something I think should happen from the age of 3 years. It should be a step-by-step process. And the way we would do this within our own unit, when a child is well established on a semi-solid protein substitute at the age of 3, we would start giving an additional 10 mils of liquid protein substitute that we would give daily for a week or 2. Once that child is taking that well, we would increase the volume to 20 mils, 30 mils, 40 mils, until we get to an entire pouch. Once we get to an entire pouch of liquid, then we replace 1 dose of the liquid protein substitute with 1 dose of the semi-solid protein substitute. And it's really important to embed the liquid pouch into the children's routine before then moving up and replacing the 2nd dose and the 3rd dose. And I'm going to use that word a lot today, embedding the 3rd stage protein substitute into the regime. We've already heard about many of the factors that will affect the protein substitute transition between 2nd and 3rd stage. These are the things that I believe are important. Firstly, contextual factors such as caregiver support, their attitudes, their motivation, anxiety. Sometimes you see parents who are very anxious about the process, which will have an impact on the child. The consistency of the process. Other siblings with PKU and generally the attitude of other siblings can make a difference. The routine, and the timing of the administration of the protein substitute and how well this is spread out. But in addition to that, the age of the child is important. The reason why we say from the age of 3, this is when a child is getting a little bit more mature. But the child's character, the personality, the behaviour they exhibit will all affect that process. If a child has some cognitive impairment, or they may even have some autism, that will affect the process. They may be more neophobic in their approach to changing protein substitute. Frequent illnesses with children, often children get a lot of intercurrent infection, and you will see from the case studies that has a massive effect on successful transition. Taste preferences and food aversions are important. But also the familiarity, the stability, the security they get from taking their usual protein substitute is a mega factor in successful transition. And finally, we have impact of the protein substitute itself. We need the right nutritional composition, but the volume, the smell, the temperature of the protein substitute is very important to little ones. They can be really quite sensitive to this. the thickness, the viscosity of the protein substitute, whether it leaves any chemical sensations in the mouth. Taste fatigue to a degree is important. The format, whether it's liquid or powder or gel, and the ease of preparation, of course, is important for the parents. So let me take you through the first of the case studies. I've got 4 case studies for you today to present, and I will highlight the difficulties with protein substitute transition, and I say how we managed to get over this, or how we are in the process of getting over some of these difficulties. The first child I'm going to talk about is a little girl. She's now 4.5 years old. She's Pakistani origin. She's got 3 other siblings without PKU, 2 older siblings. Like all our cases today, she's diagnosed by newborn screening. She's got classical PKU. She had a very high phenylalanine level on diagnosis. When we started treating her, she was formula fed for a phenylalanine allowance from normal infant formula in combination with phenylalanine-free amino acid formula. She was weaned at the age of just over 3.5 months. She was quite early age for a weaning. She started the semi-solid protein substitute at 6 months, but I'm afraid she had a fairly unhappy relationship. And this was a very special little girl in the family. She received a lot of extra attention because of her PKU, and particularly associated with the protein substitute. And Mum, quite understandably, had got quite fed up with the 2nd stage protein substitute. She wanted to transition early to the 3rd stage protein substitute and asked if she could do this at the age of 3 years. And she went from a semi-solid protein substitute to a liquid pouch. Unfortunately, the process was quite rushed. We started off with our step-by-step system. It seemed to go very well. In the first week, Mum was very pleased with this, but actually the child ended up being changed over to 3 doses of liquid protein substitute within 2 weeks. Unfortunately, the progress with the transition was very short-lived. What actually happened, the mum, the dad, 4 grandparents, all the siblings and other relatives got involved in administering the liquid protein substitute. Each one of them had a very different approach. Some of the grown-ups insisted that the protein substitute was completed. Some of them allowed it to be partly taken, and protein substitute was left in the pouch. It got to the point where each dose took 1 hour. The blood phenylalanine control deteriorated. Associated with this, the child became more difficult, became stubborn, refused to engage in the protein substitute administration, certainly was quite inconsistent and challenging. The family gave the child incentives to try and take the protein substitute, but it went from stickers to a new dolly to a new colouring book. All the time the incentives were getting that little bit bigger, and the child was holding out for an even bigger incentive in order to take the protein substitute. Mum became exhausted with the entire process. Arguments started between Mum and Dad, and the older siblings got distressed with the entire process. She started nursery. The little one didn't cooperate with nursery at all. It was taking far too long, and the whole thing was a huge problem. The child was very bright. She understood what she was doing to her family with protein substitute, but she wasn't going to stop. She had everybody in her hands. We tried alternative protein substitutes, including GMP, and to our surprise, the child did take this quite well, but it was the mother who wanted to stop the the GMP, because she had to reduce the phenylalanine content from the phenylalanine allowance from the food. This was just too much for the mother, and she asked if she could return to the semi-solid protein substitute. And in turn, the blood phenylalanine control improved again. And in fact, the child was a little bit better with taking the 2nd stage protein substitute. And she remained on the 2nd stage protein substitute without too many difficulties until recently. And then she started school. We asked the school to give 1 dose of semi-solid protein substitute, and we had initial difficulties. Different teachers were involved in administering the protein substitute. Again, the child then played up in school. She wanted her mummy to come in and give it to her. But we did a lot of education with the teachers. They became more consistent people at giving the protein substitute. They stuck to sticker rewards, but nothing more. They used time clocks to time the child taking the protein substitute. And I'm pleased to say she's getting much better. She's got a good routine, and this child is growing up rapidly. She's maturing, and now she is finally, I think, ready for the transition and ready for the change. So we're going to give her another 2 or 3 months within her school, embedding that nice routine she's got now, and then we'll start introducing the liquid protein substitute. And I think we will be much more successful this time. She is much more ready for it. She knows what's coming, and we will break through, I'm certain. The second case study is different again. This is a little boy who's just over 3.5 years. He's got one older sibling with PKU who's very good at taking liquid protein substitute. This little boy was identified at 2 days old by a sibling screen, but we know he's got classical PKU. He started off in life by being breastfed together with a phenylalanine-free infant amino acid formula. He was breastfed for 3 months. He was weaned at the age of 4.6 months, and he started a semi-solid protein substitute at the age of 6 months. And in contrast to the first case study, this little boy had a very good relationship with his semi-solid protein substitute, but his mother knew how easy the liquid pouches could be, so she was ready to move him on at the age of 3 years. We advised a step-by-step process, but this was a very busy household. Mum and dad, highly independent, they're highly capable. The child was a very busy, talkative, bright, but quite demanding child. He certainly knew how to press the buttons of both parents. He knew how to get his own way. This is another situation where the parents rushed the transition process. They didn't want to do it step by step because it was such a bright boy. They had high expectations of this child, so they changed to 2 liquid pouches of amino acid protein substitute within 6 weeks. It was going well until the child developed gastroenteritis, and he was unwell for 2 weeks. It led to poor metabolic control and low child cooperation. He took the semi-solid protein substitute quite well at this time, but he refused the liquid protein substitute completely. And so we had to go back to 3 doses of semi-solid protein substitute. To be fair to the parents, they were motivated to persist with the liquid pouch. They knew the advantages, but the volume was a bit of an issue. And also they had quite an inconsistent approach. The protein substitute was given at inconsistent times. He would play up. He would only take the liquid protein substitute if he went in the car and went on in a ride in the car, and he was allowed to do this. The parents would give in and stop giving him the liquid protein substitute when he exhibited any type of naughty behaviour and go back to the powdered protein substitute, and they would allow him not to complete it. He went to nursery, we involved the nursery, we asked them to give a dose a day, but the mum wasn't happy with their approach because sometimes he would come back with spilt liquid protein substitute down his t-shirt, so he changed nursery. Now we're working with a new nursery. He attends there every day for 30 hours. That is really good news. Is now taking 1 dose of liquid protein substitute well. We're aiming to change him over 2 dosages in his new nursery, but we need to embed the familiarity of the security liquid protein substitute into his daily routine. But I'm fairly confident now. We've got a good nursery. They know what to do. They will follow the instructions. We will move him over to 2 doses fairly soon, and then 3 doses. Our next case study is different again. This is a 4.4-year-old little boy, and different to the other children, Mum has PKU. And she had a long history of problems with neophobia and protein substitute issues. I also looked after the mummy when she was a little girl. And she did have high blood phenylalanine levels during pregnancy, and that may be relevant to some of the difficulties that this little boy has. He was identified by newborn screening. He had a very high blood phenylalanine level, and he has classical PKU. Mum did very well breastfeeding this little boy. He was breastfed for 5 months in combination with a phenylalanine-free amino acid formula. He was weaned at 5 months, and he started again his semi-solid protein substitute at 6 months. He's always been a poor eater, always been frightened of trying new foods. He's had poor growth. He's been on the 5th percentile for his length or height, and the 2nd percentile for his weight. And I think it's fair to say he's another child who's had an unhappy relationship with his semi-solid protein substitute. Every single illness he has, it goes wrong. We have difficulties re-establishing the protein substitute. Again, it takes a little bit of time. We've got to do a lot of counselling and a lot of support. But saying all of this, he's had brilliant blood phenylalanine control, really fabulous control in every way. He does have some developmental issues, some delayed speech, some poor attention, and I think some of this again has led to some of the difficulties we've had. Mum wanted to introduce liquid pouches of protein substitute at nursery. She didn't want to do it at home to start with. The little boy was used to seeing liquid pouches of protein substitute because that's what his mummy took. We started introducing things step by step within his nursery. We got 4 to 40 mils a day. Things was going really quite nicely. Then the child had an intercurrent illness. Then he refused to take any more liquid protein substitute. So we had to continue with the semi-solid protein substitute, but not happily. Again, we struggled with every single illness. We followed the same pattern. But to be fair to the parents, they were still keen to transition, but really wanted the help of nursery to go with them. On the whole, we continued with this semi-solid protein substitute, and recently the child has started school. Things went badly wrong when the child went into the school because different people was giving him his semi-solid protein substitute. He refused to take the protein substitute both at home and within the school. And things were going badly wrong until the school said, look, we'll bring in the nursery teacher. There was only next door who used to give the protein substitute to him when he was in nursery. At that point, we had turning point. But the parents said, look, we really want to really crack on with transitioning to the 3rd stage protein substitute. We respected this. And they wanted to move on to GMP powder. So with a lot of education within the nursery, with the use of timers, pictures, aids and stickers, the use of one carer, believe it or not, we've got him on to a sachet of GMP mixed into a liquid fairly quickly. Again, we will ensure that this is embedded into his routine before we change him over in the home environment, but this is one now we're confident that we will move him on. And again, our final case study is different again. This is a child who's almost 5 years old. She's got 3 older siblings and a little baby sister with PKU. 2 out of the 3 older siblings have medical issues, so there's a lot going on in this family. It's a very busy household. Again, this little girl with PKU was diagnosed by newborn screening. She's got classical PKU. She was formula fed with normal infant formula together with phenylalanine-free amino acids when she was first diagnosed, weaned just before 6 months, and she started a semi-solid protein substitute shortly afterwards. She's had a number of problems as she's been growing up. She's got a long medical history, not only of a PKU, she's had a number of chest infections, she gets broncholytic, she's had a number of vomiting episodes, she's had problems with her teeth, she's had at least 7 of her first teeth taken out by the dentist. She's had seizures, frequent gastroenteritis with diarrhea, couple of breakages of bones, and you name the childhood illness, she's had it. We've had poor and inconsistent metabolic control, and some of this has been not only due to problems with the protein substitute, due to problems with the illness, but some dietary errors as well. Now, this child, I think, partly connected with a poor control, has been a little bit of a wild child. She's been quite stubborn and cooperative. For quite some time, nobody's been allowed to brush her hair. Parents really absolutely exhausted, not only with this little one, but with other problems with the other children. And again, another one with an unhappy relationship with a second stage protein substitute. She would commonly spit this out. The routine was poor, a lot of inconsistencies. Because of the problems, we started the liquid pouch at the age of 3.5 years. We aimed to start a stage transition process, did a lot of education on this, but it wasn't adhered to. The parents wanted to rush the process. They hadn't got time for this. The approach wasn't particularly consistent. And within a couple of weeks, phone call that she was being given 3 pouches of the liquid protein substitute a day, and they stopped the semi-solid protein substitute. She was only being given 30 to 50% of a liquid pouch in any one day, and her control deteriorated even further. We had to do something. Just before the age of 4 years, we tried her with GMP, and to our relief, the child liked this. This is where we hadn't got time for a slow transition. She had to go onto it completely because we got nothing else to fall back on this. She got classical PKU, so we had to calculate the phenylalanine from the GMP, from a dietary allowance of phenylalanine, so it reduced phenylalanine exchanges. But at last we had a child who had a protein substitute that she actually liked. There's still a little bit of an inconsistent approach with this, but it was better than before. Parents offered this 3 times a day, and bit by bit, blood phenylalanine control improved. With this, the cooperation of the child improved. She started nursery at the age of 3 years, but she only went to nursery 3 days a week, and the attendance was a little bit consistent. But my goodness me, we've had breakthrough recently. She started school. She's attended every single day. We've done a lot of work with the school. The attendance is consistent. She's now developed a good routine. The school give 2 dosages of protein substitute. That has taken a lot of burden away from the parents at home, and she's taken 2 dosages of GMP really well. And now we've got nice control and everything is going fairly well. So we've moved on, and I think we won't look back. So what has gone wrong in all of these case studies? Well, we've had a lot of manipulation, control and defiance going on by the children. And this has happened when the parents maybe haven't completely persisted with the 3rd stage protein substitute. And the children have used hurtful words. They beg the children not to continue with the protein substitute. Every time the 3rd stage protein substitute is brought out, they will say, "I need the toilet. You hate me for giving this. I promise I will take it later," and later never comes. "And I hate PKU." And of course, this sends the parents on an immediate guilt trip. And the parents feel very horrible and upset and frustrated. And many of them are still coming, it's quite early on in their childhood life. Many of the parents are still getting to grips with the idea of PKU. Some of them are still, even grieving the diagnosis of PKU. But we've got to work very closely with the parents. They've got to gain control. The other thing, when it goes wrong, we see low parental resilience. This is often when parents are quite negative towards the PKU. Some of them maybe have low education, big families, low patience, inconsistent. They maybe leave the child alone, unsupervised when taking the protein substitute. They're using consistent rewards. But all of this is understandable. You know, this is hard work, what we're asking the parents to do. We need to support them. We have to remember that our parents are human, and we've got to do everything we can. We've got to help them in every way we can, not criticising this situation, because it's a hard job that they have to do. So what can we conclude? Well, the transition process will take time. It shouldn't generally happen overnight. If it happens overnight, we may run into difficulties later on. But we have to remember that it is a process we've got to work through. We shouldn't delay it. We shouldn't put it into the too difficult box. If at first it goes wrong, we keep trying. We go back and look at what we can do. We try again a little bit later, but it's something we've got to work through. Both the caregivers and the child have got to be ready for the change, and we've got to do that education there. Life changes and frequent illnesses can derail the process, but again, we've got to sit back, look at what we can do and move on. One of the things that I see is that sometimes caregivers think that transitioning is going to be really very easy. It's important they don't have any false expectations of transition, that they don't expect the third stage protein substitute suddenly to taste wonderful. You know, we could give a child nectar to take, but it doesn't mean to say they will take it, because they're not used to the taste or the smell. Whatever we give them in that situation, it's going to take time. And I think it's really important that we involve the nurseries and the schools. In all of the case studies that I've shown you today, it's the school and the nursery that are helping us get that breakthrough, to get that successful transition. So they really should be very much part of the process, and we should include them in our education programme. So that is all I've got to say today. Thank you very much for listening. And now it's time for our question and answer session. And back to you, Owen.
Thank you. Thank you, Özlem and Professor MacDonald, for your very interesting and thought-provoking talks. I would now like to open the session to questions. Özlem, you captured 110 responses from 32 countries. Were you surprised by the variety of management strategies used for transition, or was it broadly what you expected?
So, well, I mean, I thought there would be some differences in how is the transition process managed, given that there is no clear guidance out there. But yeah, I was quite surprised by just how much it varied. I mean, thinking about the transitioning age, like it varied widely, and the transitioning duration, and the transitioning methods that healthcare professionals use, they quite differed between the countries and even within the same country. So yeah, I even received responses from the same hospital. I received different answers from the professionals who work in the same hospital, but follow a different approach. Yeah, so I think it was surprising to see this much variation.
Okay, thank you. I think you've kind of answered my next question, but did you spot any interesting regional patterns, such as, you know, in South America they do this, or in the Middle East they do this, or is every country different? I mean, I know you said even sometimes centers, the same center can be different, but did you spot any patterns? So,
I mean, as I said, I didn't see like many different patterns, but I did see some differences. Like, for example, professionals from South America, they often reported about they are struggling with the limited protein substitute options available in the market. So, and most of the Middle Eastern countries, for example, they do not have GMP protein substitutes available. But other than these, I haven't seen, I don't remember seeing any other clear patterns. As I said, yeah, it differed between countries and even within the same country.
Okay, great. No, thank you very much. Professor MacDonald, educational videos were identified by 53% of survey respondents as a useful resource that needs developing. What do you think would be the #1 message that you feel needs to come through in these videos?
Yeah, it depends whether the educational videos are aimed at parents and the children, or whether it's aimed at the professionals. I think one of the #1 messages for me is that for professionals is that we start educating our families early, so they know that transition is going to happen when it's going to happen, but also that it's not going to be an easy process. And I keep using the word process, but it will take time, and it's not always about the protein substitute taste and the flavour. That it's more about, you know, the child has got a deep-seated relationship. Even if it's a poor relationship, they've got a deep-seated relationship with the second stage protein substitute. And we are dealing with children that we know may have neophobia, and that's going to take time to overcome. So that has got to be a very strong message to the professionals, that it is a process that they have to work to, and it's not going to happen overnight. If it happens overnight, as you've seen in a couple of case studies, it goes wrong very easily as well. And you know, and it may end up with people not transitioning the protein substitutes. What I think we actually need for our families is little videos of stories where it's worked and not worked, but then has finally worked. A little bit like the cases I've talked about today, but I think it's important for children that they see other children taking protein substitute. They will copy other children. You know, it's the right thing to do. They know it's part of their normal life. It's like going to school, that it's something they've got to do with time. It's like potty training. It's something they've got to learn with time. So we need little videos that the children can see, and we need videos for the parents, of other parents chatting, talking how they've gone through the process, giving little tips of maybe what they've done that's helped them, and how they persisted and not given up. So those are the things we educational tools that we need out there, and anything that is available for the families, it needs to be readily available, that they can access very quickly on websites or from apps, that it's there when they need it. But that's what we could do with right now.
Okay, so not just stories of success, but stories where initial adversity was overcome.
Yeah, life isn't perfect, and I think we have to accept that often things will go wrong the first time, if not the second time. But all of these problems you can overcome. I think we're fooling ourselves if we think that there is easy transition out there. That's generally not the case. It takes time, but people will get there, and that's the message that I need our families to understand, not to get disheartened, to keep going. This is part of growing up. It's part of parenting. It's part of how children are, and nothing's easy with parenting, and neither is this process, but we've got to work at it.
Okay, great. Do you accept a slowing in growth when transitioning from second to third stage? Is this acceptable? If it's just temporary, what would be your thoughts on that?
It usually isn't a problem, I mean, to be quite honest. What can actually happen when we go to second stage to third stage, there's often a little bit of a calorie deficit. So sometimes you see that we've got to be a little bit careful. Sometimes you see the phenylalanine levels slightly increase because of the calorie deficit. But it's usually very short-lived. And the great news is often when we go to the third stage protein substitute that the appetite picks up, and the children will start eating a wider range of foods, which is a plus of moving to a liquid protein substitute. I think it fills the children up less. So generally, not too much problems with the weight. It might slow down, but if we just continue to monitor that and watch around that, it's generally not an issue. But I don't see weight gain as a problem, but you can see a slight knock-on effect on appetite, but not enough really to affect nutritional status in any way. I would say in 90% of the cases anyway.
Okay, great. Another question for you, Özlem. Were you surprised that the number of healthcare professionals engaging with the schools and the nurseries wasn't higher? I think it was roughly a 50-50 split, wasn't it? That half did and half went. Were you surprised by that?
So it was even less. Like the healthcare professionals who engaged was 30% of the professionals who responded to the survey. Yeah, I mean, given that this transition happens usually happens when children start nursery or to school, I was expecting nursery to be actively involved in most of the time, but like around 10 out of 110 responses, so it's around 10% or maybe less than 10% said they actively involve nursery or school during the transitioning process, and other than that, the nursery was either passively involved or only involved when they are needed, or parents take the initiative to contact themselves. Yeah, I was expecting it to be a little bit higher, more as well, I think. Yeah.
Yes.
It was in total like 30%, and active involvement only takes less than 10% in total.
Okay. Right. Yeah. No, especially when it sounds like they can be such a great source of support. So yes. Another question for yourself, Professor MacDonald. Any advice on how to transition a 3-year-old child with poorly managed PKU, taking third stage protein substitute from a baby bottle and refusing to take this as a drink from a pouch or cup?
Yeah, that is always very hard, and to be quite honest, this is exactly where I would involve nursery, and because even though little ones are maybe won't do it for the mummy and daddy, with a lot of encouragement with nursery, this is where they will change. But it's about getting the child in nursery, in Britain, trying to negotiate 30 hours a week. And what I would start with is doing the 10, 20, 30 mils. Child can still have it in the bottle because got nowhere to go. But it would be to say you've got the 10, 20, 30 mil rule. But maybe in that particular case, I would start with something, a different taste. This is one where I would consider GMP for a 3-year-old, a different taste, doing it in nursery, doing it for a consistent nursery teacher, and they get the time clock out, they get the stickers, and it may not go very well for a week or two, but it's amazed how good they can get children into a good routine. But you almost, when they're out of control, and this is a little bit like case study number 4, the child was so out of control at times, it was very difficult to work with the little one to get them to listen, to get attention. But it's once you find you start bringing the levels down, then you'll have a child who you can cooperate with again. So it's worth saying, well, this is something a little bit different. This is something we've got to do, but to put it in a very strict environment, whether with a nursery teacher who's kind, but also sets the boundaries, very clear boundaries, and eventually you will win through.
Great, thank you. And I think that's it for the questions. If we could move on to the final slide now. I would like to thank all our delegates for taking the time to attend today's webinar. We hope that it has been helpful for your practice. Please complete the feedback form which will be in the post-webinar email you will receive. Thank you also once more to our speakers, and goodbye and enjoy the rest of your day.